Hi, this is Chloe Belisle presenting on lower crossed syndrome. Lower crossed syndrome was a term coined by Vladimir Janda in the 1980s. It involved hip flexion and lumbar hyperlordosis. The concept of LCS was further explored by Josephine Key. She divided LCS into two subcategories. The PPCS, or posterior pelvic cross syndrome, was identical to the classic LCS as described by Janda. APCS, or anterior pelvic cross syndrome, was the exact opposite. APCS involves hip extension and lumbar hypolordosis. I have a picture here that might help you visualize that. And just keep in mind that the anterior and posterior in the names refer to the shift in the pelvis, anterior or posterior to the plumb line, and not to the pelvic tilt. These two subcategories share similarities in that there may be underlying weakness in the abdominals, glutes, TA, pelvic floor, multifidus, and diaphragm. The demographics of LCS is not well studied. However, one small study in India revealed that 36% of young women and 12% of young men had classic LCS. We would expect LCS to progress with age, but we don't have a lot of hard evidence for that. A common mechanism of injury is poor sitting posture, age, and proprioception deficits that may be the result of trauma. The pain pattern for LCS largely depends on the specific diagnosis of the patient. So please keep in mind that LCS is more of a contributing factor rather than a diagnosis in and of itself. However, pain with LCS tends to get worse with sitting and prolonged postures. Easing factors may be low intensity motions such as walking. Sleeping may or may not be easing depending on the posture that they adopt during sleep. A systems review is probably not necessary unless there are other concerning signs and symptoms that you uncover during your history. There are no specific precautions or contraindications for LCS. During the exam, we will talk about classic LCS or PPCS. Keep in mind that APCS is going to be almost the exact opposite of PPCS. During our observation, we will notice excessive hip flexion and lumbar hyperlordosis. During gait, we will notice a lack of hip extension and decreased stride length. Active and passive ranges of motion will be limited in the same direction, so limited hip extension and limited lumbar flexion. CUT may reveal weakness, but it should not reveal pain if it is purely LCS. MMT may confirm weakness in the abdominals, glute med, max, and TA. For accessory motion tests, we have the PIVMs and PAVMs. These may reveal lumbar hypermobility, particularly in the lumbar region, lumbar hypermobility, and possibly hypomobility in the thoracic region. They may also reveal limited lumbar flexion. We would expect special tests, neuroscreen, neurodynamic mobility to all be normal. Palpation may reveal trigger points in the erector spinae, as well as increased muscle bulk, trigger points in the iliopsoas, decreased fascial mobility. It is important to include cauda equina, cancer, infection, and compression fracture in your differential diagnosis. Diagnostic imaging is not routinely performed for LCS, and it has a very high false positive rate. So keep this in mind. Red flags to look out for are age, over 50, weight loss, history of cancer, unsuccessful Petri treatment, signs and symptoms of a UTI or a recent UTI, substance abuse, particularly those requiring injection, immunodeficiency disorder, incontinence, numbness, progressive or global weakness. And those all relate back to tumor, infection, and cauda equina. Surgery is rarely needed for LCS. However, disc herniation and other problems may require surgery. In this case, herniation with radiculopathy has a high success rate for surgery. This concludes my presentation.